across India and the US in the wake of this COVID-19 pandemic. Before we get started with our session today, a quick introduction to the new entity that Emory has formulated in India. This legal entity announces Emory's formal and official presence in India. As you know, Indian students form one of the largest groups on Emory campuses. A large number of alumni are spread across major Indian cities. A number of accomplished faculty members across different disciplines have research collaborations with Indian partners, including with the Public Health Foundation, from where we have one of our panelists today. And also another exemplary partnership is between the Emory Vaccine Center and a premier research institution in Delhi, where the work is focused on infectious diseases research, including that on COVID-19. Building on these activities, the focus of this new Emory entity in India is to strengthen and expand Emory's footprint here. And with this, I would like to extend a very warm welcome to our panelists. We have with us today Dr. Marianne Bobilski, Dr. Rajmohan Panda, Ms. Prachi Garg. Thank you so much for joining us, the three of you. Before we get started with the discussion, I'd kindly request each one of you to give a brief introduction of yourself and a quick overview of your research interests. Dean Bobilski, if we can start with you, please.
Sure. Well, thank you very much for that introduction, and thanks very much to the organizers and to my fellow panelists from India for participating in this event. I'm Marianne Bobilski. I'm Dean and Asa Gergs-Candler Professor of Law at Emory University. I have, in my role as an academic over many years, studied public health law issues, including the legal aspects of infectious diseases, and also have an interest and have done work in comparative health law, that is, looking at how different countries around the world deal with common challenges in public health and other areas. And it's a great honor to be with my fellow panelists today, looking at this important topic.
Thank you. Thank you so much, Dean Bobilski. Dr. Panda, if I may request you to introduce yourself, please.
Thank you, Nikhil, and thank you, Emory Alumni, for having me here. I'm Raj Panda, and I'm a preventive medicine specialist, trained in public health at Emory in 2005, graduated in 2007, and I work currently as a professor at the Public Health Foundation of India. My area of work is primarily primary care and providing evidence-based medicine and policies for policy change, and also working in the area of policy research for universal health coverage. I do a wide variety of different designs to evaluate programs in public health and also engage with training and teaching in the schools of public health that we have under the Public Health Foundation of India. Thank you.
Okay, thank you so much. Warm welcome to you again. Prachi, if I may request you now, please.
Hi, thanks, Nikhil. Hi, I'm Prachi. I currently work for Roche, India, as National Policy Lead, and my work currently focuses on cancer, hemophilia, and rare diseases. And at Roche, we are trying to understand how to market access issues of various therapies, especially in the non-communicable area space. My core interest area in terms of public health is digital health, and how over years it can be used as a health system strengthening tool. Thank you, Nikhil.
Thank you, Prachi, and very welcome to you again. Great. So thank you so much. We're looking forward to addressing some key questions in this policy landscape across different areas linked to your individual expertise. So I would start with, and just to reiterate for the audience and for our panelists, this will be a discussion, and then we also invite questions from the audience, and towards the end we would be taking some of them as time permits. And to get more insight from our panelists on things that may be of interest to the different audience across the globe, and of course in India and in the US. So with this, Dean Bobilski, I would like to start with you. So we understand, with this whole COVID-19 pandemic, it has, presented us with challenges that we have. I mean, it seems like one of the greatest sort of era where we have never experienced something like this before in a long time, which has impacted you know, life across different spectrums. And with this, a key area becomes policy formulation, implementation, which help in getting through this and also preparing us for similar situations in the future. With this, I would like to understand from you, like, how does the design and implementation of policies across various states in the US work? You know, we understand that policies are made at a central level and then implemented across different states. And as they are formulated and implemented, there may be differences to each of those things from a state perspective. So we would like to understand how that system works and what impact does it have on people's life and safety and health as they are implemented across these different states in the US.
Well, thanks very much for that question. And it's a big topic, and I want to do honor to my colleagues by not speaking at too great a length. But I'll just say that this is a very significant legal issue and policy issue in the United States as it is in India and other countries. It's the idea of thinking about government and saying, what does the constitutional framework or the framework of government say about which part of government has power over what part of public health? In what ways does a central government, the federal government in the United States, contribute to protecting us from the pandemic? And in what way do the states have a role in protecting us from the pandemic? And in the US system, the federal government, the national government, has very important duties in helping to keep disease out of the country and in regulating certain areas, like, for example, government regulation of vaccines and new drug therapies. And it also has an extremely important role in what's called spending, the spending power. It spends money and creates expertise at the federal level in different ways. For example, the Centers for Disease Control and Prevention, which is a world-leading public health organization, is located right next to the Emory University campus and is funded and created by the federal government to create expertise in public health. But one thing I didn't mention in that list of things that the federal government does is I didn't talk about direct protection of people from threats to health and safety. And a lot of the power over public health and the development of public health policy and implementation of public health policy actually happens at the state level. And as I was asked in the question, this creates differences across states and how public health policies are implemented. To take one example, all the states across the United States have had to determine whether or not to have stay-at-home orders, the orders that encourage people to avoid contact with others and to protect themselves from the pandemic and to protect others from the risk of acquiring the disease by staying at home and staying out of contact with people. Those states have taken very different approaches, either in when they have decided to implement stay-at-home orders, the ways in which they've been implemented, and the ways in which those stay-at-home orders have been lifted. So you can have very significant differences in how the states are doing what's called exercising the police power. It's a technical term that means the power of state governments to protect the health and safety of their citizens.
Thank you so much for that overview, Dean Babinski. I think building on what you just said about the federal structure and the state structure and the key parameters on that, I think I would like to move to you, Raj. Get into a little bit more sort of specific granularity here, because we have a similar structure in India as well. And while there are some overarching parameters and pointers to what were pointed out, there would be some specific areas which play a critical role in designing and implementation of these policies more from a perspective of a state level, and given the diversity here from an India perspective and in each of the states. From you, I would like to understand, given your experience, what are these various parameters? One parameter that comes to mind is data and models that are derived from this data. So I would love to understand from you how, what role does, what are the various parameters, and in that context, what role does data, which is one of those critical parameters, and the models that are based on such data, what critical role do they play, and how does it differ from state to state in terms of, outlining this data and using this data for creating models for addressing, response to a pandemic like the COVID-19, or designing policies for such pandemics and other areas. One is this, and I would also request if you could highlight, some areas which could help us in strengthening these data collection and data modeling systems for having more relevant and better impact across different states in the country.
Thank you, Nikhil. And absolutely, and the contradiction is not is more so in countries like India, which is also has a similar structure, but where their response is very different. But before we go to data, I would really take a little time to, get to what the policy was and how the policy was very different from what probably Dean just talked about. And I would like to start my overview with a quote by Dickens, which probably summarizes what we are going through in these times. And Dickens begins his tale of two cities with a vision that human prosperity cannot be matched with human despair. And he says, and he talks about contradiction. He says, it's the best of times, it is the worst of times, the age of wisdom, the age of foolishness, the epoch of belief, and the epoch of incredulity. And incredulity it has been, because the policy response of the government, which although in the beginning was very good, has also been full of contradiction and compromise and confusion. And this is not to say that the government did not get its act together, but the public health policy response has really exposed the fault lines that historic neglect of the public health system in India actually has had done, and also the fact that there are two worlds in which Indians live. One is India and the other is Bharat. And the policy and the data from these two different worlds are very different. Let me explain. The policy of social distancing and frequent hand washing was based on some Western models and, of course, basic epidemiological measures, which was perfect when it was applied to the world of urban middle-class people. But when it came down actually to, the large unwashed masses who live in slums and low-income settlements, and India is home to one of the largest urban settlements with below poverty lines, then that did not work. And as for data, even in normal times, it is difficult for us to actually look at, to gather data from there, and even from rural and semi-rural areas. So at best, even the best model that has been done in India till date has a lot of loopholes, because data was not easily available. A, data was not collected. B and C, data was not readily available in public domain, not been shared. And I bring this to your notice because with two examples, because the IDSP, the Integrated Disease Surveillance System in India, which collects data for infectious disease, has stopped putting data in public domain from February 23rd. So we are not even reporting infectious diseases like influenza and other things. So forget about other things like data modeling. And somebody who's collaborating with the US university, in this case, University of Michigan, to do district level local data analysis, it's really, so to say, quite despair, because the data that we are getting is quite outdated and redundant, and one has to make a lot of postulations and a lot of projections that may not be the right mixture to actually take the modeling forward. So in the absence of data, how do we actually have evidence? And then there is this whole conundrum that, you do not have evidence, so how can you have interventions? And because you do not have interventions early on in strengthening your public health system, you are now left with, almost no data.
Is there, just to build on that, is there a difference in systems and approaches for this collection and use of data across different states as well? And is there a way to homogenize, these approaches so that from a perspective of a pandemic like this, the COVID-19, where, the approach is that there is a uniform sort of interventional policy or systems, so how does that work across different states in terms of data?
Yeah, that's a great question that we have been pondering for some time. So let's remember that India's public health system and the entire COVID pandemic is really public health, mostly been in the public healthcare system. I mean, private healthcare has co-opted, and there are some private corporate hospitals which has co-opted to be COVID hospitals. But by and far, these hospitals of this magnitude with the diagnostic facilities and the ability to treat the kind of treatment in COVID is just not there in rural areas, on semi-rural areas. And many private hospitals, including the ones which were, the mom and pop clinics to the 10-bed hospitals, have really winded up because they're just not sustainable. On top of that, which means if you have 2/3 of your OPD and IPD actually being there in the private health system in India, it is very difficult to actually convince the private healthcare to give data when the incentives are not enough. So now the government has adopted a carrot and stick approach, but the stick doesn't seem to be working anymore because the private hospitals have literally shut down. And now nobody seems to be worried about data anymore. I mean, the whole thing is how can we respond to the pandemic, but without data, like I said, it's a catch-22 situation. Without that data, moving ahead is like literally like, throwing a stone in the dark and hoping that you will hit something. And this is the limitations that the government has. The government is trying its best. I would not say that the government is not making efforts to get the data, but historic neglect has such that the public health system is totally in disarray. And even the public health, and within the public health system too, public health surveillance is often the stepchild of, the financial part of it. I mean, India spends 1.2% of its GDP on healthcare. I mean, public spending is so low. What can you expect? The United States spends somewhere around 19 to 20% on GDP and still has such problems. So just, I mean, it's really, the contradictions are huge. I'd like to again make one small point that Dean said, and in India actually it would have been better if there would have been a more decentralized approach to the pandemic, because states have the power to actually move ahead with data and also to move ahead with intervention. It is not that they were not allowed to do so. Definitely they were allowed to do so. But the initial phase of lockdown was a very centralized phenomenon. So what did not work for the United States would have worked for India, because India is very diverse with different political, factors playing out to control the pandemic.
Thank you so much for that, Raj. And I think, like they say, in every crisis lies an opportunity. So I guess, like you rightly mentioned, the positive aspects of the current response, and hopefully moving forward, addressal of certain key areas that can help in bringing the different stakeholders together in responding to something like this that I guess we and the world have never experienced before. But on that note, on the things that you mentioned about the role of different players, how the private hospitals and the private players have responded, and the response across different states on the COVID-19 pandemic, I would like to move on that note to you, Prachi, with your experience at Roche, from an international pharma biotech company perspective that is working on different products, on different disease areas. We would like to understand the context of the effect of COVID-19 on the general health perspectives, health issues, and policies related to that for non-COVID related health concerns. We have been hearing how people with cancer, people with other chronic disease areas, in the Indian context, there are a number of other infectious diseases and concerns like TB, HIV. So from that perspective, what impact has COVID-19 created on access to healthcare and safety for patients and the population that is suffering from these other diseases, and from a context of the negative impact that there may have been in these non-COVID related issues, how do you envisage, moving forward, we could create a better ecosystem where, while we are struggling in addressing the challenge of a pandemic or any other problem, yet we are not, completely foregoing or partly even foregoing these other critical areas that are important for the whole healthcare system. Prachi, I think you're on mute.
I just realized. Thanks, Nikhil. That was many questions in one large question. And uh, honestly, over last decade and a half, I've worked in government, I worked in consulting, and now I'm working in a pharma company. So I have seen all sides of the story. And Indian public healthcare system is so complex that it requires an entire semester to understand. So, I mean, summarizing what Raj said, I would like to just take you through the challenge systematically. So, in India, healthcare is a state subject, and we have a federated system which is extremely fragmented and often very difficult to navigate for a patient. And you can imagine we are a population of 1.3 billion people, and a very small proportion of this population uh, uh, can afford the health services offered through private healthcare. But as Raj mentioned, 65% of the population in India depends on private healthcare system for service delivery. And it would be very interesting to note that 95% of all hospitals in India are smaller than, in their size, smaller than 10 staff as facility. So that adds to challenge. So when you think of private healthcare system, don't think of large corporate hospitals that you see in US. Most of these are small clinics run by individual doctors or a group of 2-3 doctors with a small staff. uh, but still, I mean, the interesting part is, if you compare it to American healthcare system, the perceived access and availability of healthcare system is very high in India. If you would ask an average American and an average Indian about this question, you would find a favorable response. Uh, and another thing that adds to this complexity is the payer systems. So India, if we look at it from the classical definition of payer systems, India has all four models of payers: beverage, Bismarck, out of pocket, and of course, state health insurance. Uh, we have Ayushman Bharat launched by India recently with the vision of universal health care, which covers roughly 40% of the population, which is below poverty line. If you look at Delhi, the city where all three of us live, I was doing some research and I figured out we have 14 different payer systems in Delhi alone. And each one of it has its own patient flow. Uh, Now, since out of pocket covers roughly 650 million people, uh, it remains the key service provider. And if you would have seen in over the last uh, half a decade or a decade, there was a uh, uh, starting with schemes like Arogya Shri, there was a constant stress towards public-private partnership, and the tertiary care getting more and more focused in the uh, to the private healthcare system. So now, if you uh, um, so, I mean, in this context, now, if we look at the current situation, what we learned that Indian government was highly dependent on private healthcare system to provide services. But in the COVID condition, what we found that private healthcare system was not prepared to cater to a disaster situation like this. It was not only able to handle COVID-19 cases, it failed to deliver the services which it was routinely delivering to patients. So, and cancer is one of them, and you can imagine other chronic conditions like thalassemia, hemophilia, uh, people who require dialysis on a regular basis, HIV patients. I mean, all these patients were unable to go to hospital, and even those who were willing to, I mean, because of fear of infection and a caseload on hospitals, but even those who reached, they were required to do a test, and that test was for, I mean, roughly a little about $70, which was very unaffordable for somebody who has to be in hospital every 15 days for a transfusion or for other similar services. So I think COVID has made it very clear that India needs to ramp up its own public healthcare system. The network is already there, available until the village level. It's a question of how India decides to strengthen those services, put quality infrastructure, quality providers there. I think one of the challenges which Indian healthcare system also has is the lack of trained paramedical staff. The nursing cadre, the paramedical cadre is extremely weak in India, and Indian healthcare system needs to ramp that up too. What we saw in COVID situation was the price rise, the hike of cost of therapies in private healthcare system. Uh, these days, if you are in a general ward sharing a bed with several others, you might be paying up to 500 dollars, right? 30,000 rupees roughly in a private healthcare facility, which could be affordable to even uh, middle class, upper middle class, affluent class people like us. I mean, we can't stay in a hospital paying $500 every day for even as long as a week. Uh, as Raj mentioned in his discourse, that India spends uh, very about 1.2% of its GDP on healthcare. If you would look at Kerala, it's one of the best performing states in India as its response to COVID, and also its ability to provide healthcare for non-communicable diseases, especially like cancer. It's not happened magically in one day. Kerala has spent over 12% of its GDP on healthcare for over a decade now, or I mean, not just a decade. I think it's been more than 4 decades. It could be 5. So 40-50 years of 12% of GDP spent on healthcare has made Kerala self-reliant and and enabled it to respond to such a situation. I think one of the good things that has happened in India in last 2-3 years, I think Indian government has in its health policy 2017, it was very specific about how it wants to achieve universal health coverage. So some of the challenges which Indian government will have to navigate through would be information asymmetry. I mean, I just made a list because there are about 8-9 things. So information asymmetry between providers and patients, absence of strategic purchasing both on the behalf of the government and patients, unclear uncontrolled referral pathways, zigzagging patterns that patient take within the healthcare system, delayed care, unnecessary expenditure, suboptimal overall outcome, and there is hardly any focus on the outcome itself. Lack of risk pooling. I think if Indian government would have greater data, they would be able to do risk pooling. And like Raj said, a federal decentralized healthcare system is there, but it needs to be empowered to optimal level. Uh, Indian government launched National Digital Health Blueprint last year, which is which has to be implemented, and I think
So,
it would
Prachi,
be
no, I think those are good pointers I'm sorry, I'm just trying to see the clock as well, and I have a
Yeah. So
lot
I
of
was
things
just going to conclude with my last point on the digital
Sure,
health.
please.
So yeah, so it's digital health blueprint has been launched, and Indian government would need to implement it now. I think it lays a very comprehensive federated structure for digital transformation. I think it's time to fast track it. I believe the next step to the digital health blueprint would be an open health network like a Google or a UPI of healthcare, like Raj was mentioning in his presentation. Because when the data is stored and shared across ecosystems, then a lot of challenges which we face in Indian public healthcare system, that can be solved.
Right. Right. No,
Thanks.
thank you so much for that, Raji. In fact, I would like to come back to you on the pointers that you made on certain key areas, the ones that you outlined, but also would love to understand, while you mentioned Kerala, there have been other states, like Karnataka, like most surprisingly, Uttar Pradesh, where we don't hear as much as we hear from a context of Maharashtra, or even, as a city, Delhi. And even, for example, my home state, Odisha. Um, so, would love to understand if there are any common thematic areas that have come out to what Raj mentioned in terms of fault lines that, while exposed, were also addressed by some of the states which previously haven't experienced, any such situation. While Kerala, for example, has, whether it's the Nipah or others, so hence also prepared. Has there been some common themes that have come out that have shown that states other than the ones like Kerala have also been able to, productively, proactively, and efficiently, to a certain extent, counter this pandemic? But we'll come back to that on the next question that we have for you. But again, sort of switching gears a little here. Again, I think the first bit. Sorry, I know we have less time and too many things in the mind to clarify from all of you. Yeah. So I would like to come to Dean Bobinski again. Dean Bobinski, you highlighted the structural differences from a federal and a state perspective, and there were some insights from Raj and Prachi to various specifics that help in, addressing the various challenges from a healthcare perspective, with these different structures and what importance they have in terms of the specific parameters. What I would like to understand from you, given your extensive experience from a perspective of these different structures, from the components that come in these structures, whether it's the ethics, the implementation, the accessibility, the affordability, something that a good policy ensures. What, according to, and with a pandemic like this and a virus that has not restrained with borders, what, in your opinion, are certain parameters and insights that lead to the formulation and design of good policies that have impact not only from these differences of a federal or a state structure, but also can be useful not just to a nation, to a specific region, but can be useful globally. So what would be the factors for good policy design and implementation from the different perspectives that we just discussed?
Well, thanks. Another big question. You're giving us all large areas to talk about.
I'm getting greedy here.
Yeah, you're thinking big in terms of solving the problems of the world, which I appreciate. It is a challenging question to say, well, what are the characteristics of good policy, and what can we see, what can we have learned from in the past and can be thinking about for the future. And certainly if you look back in public health and public health law policy, we've had periodic challenges, smallpox, in the more distant past, the pandemic in the early part of the 1900s that the world faced. More recent challenges around tuberculosis, Ebola, the HIV epidemic, and other types of health challenges that are very have a huge impact on human health, but aren't caused by infectious diseases, like, for example, tobacco use as another sort of health challenge. And in each of those areas, I think you can see how important it is to have investments in infrastructure and expertise. And that's been a feature that both of my co-panelists have mentioned, the extent to which governments and even private actors have been able to build up infrastructure and expertise that creates a reservoir from which then you can actually carry out healthcare policy and get that healthcare policy to have impact in the broadest possible part of the population. So those investments are obviously very important. But I think to talk about some less commonplace things, it's also important to have developed trust of people in healthcare expertise, in government, and in other actors who are working to try and address public health problems. So that trust is something that, you know, it's harder to put a dollar figure on. You can talk about how many trillions are spent in healthcare or what percentage of GDP, but that trust that doesn't have a monetary value becomes a very critical component when it comes to a healthcare crisis like the one that we're in today, and how people relate to what they're told about how to protect themselves and how to protect others. So that trust, I think, is very important. Trying to find support for what would be good public health policy, or what would be good healthy options for people can also be important. And here I'm thinking of things that may not appear to have to do with healthcare, but become quite important, like leave policies from work, for example, whether or not if you stay home from work, you'll be without economic support. And so you, faced with that tough choice, you go out into the world because of the need to earn money, but create a ripple effect in terms of public health impact on other people. So it's that outside of healthcare structure of support that provides ability of people to take the public health advice that they've been given, but not face financial ruin. Similar types of outside of healthcare direct support can be the things that are the manufacturing processes and supply pipelines that allow us to get access to basic healthcare equipment, personal protective equipment like masks and ventilators that
Dean Bobinski, I think we're not able to hear you.
Consistency around
Dean Bobinski, we are not able to hear you in between.
somewhat inconsistent definitions in different jurisdictions, and real challenges from the government perspective in understanding what data means. So for example, if you have an increase in the number of diagnosed cases of COVID, is that good? Because it means that you have more testing available and more people are being tested and you're getting more information? Or is it a sign that the infection level is growing more severe? And so you have people kind of trying to understand data in different ways. And on the last note there, I'd just say outside government, data has become much more important. And there's a reference to Google and other entities that have played a very important role in providing different types of data. Even anonymized cell phone data, for example, that allows governments and others to understand, well, how are people actually behaving? And if you look at anonymized cell phone data, you get information about the level to which people are traveling away from their homes, the level to which they're congregating with other people. And it's created the opening, as many have discussed, to have a new form of public health measure where you're able to do contact tracing because of private apps and private parties who built infrastructure to collect data that's beyond the capacity of traditional public health systems to achieve.
Right. And would you also, from a perspective of implementation of policies, would any of these parameters or any others be relevant? For example, in the current context, we have seen with the social distancing, while it was one thing to formulate that policy and put it across, it was another thing to actually implement it and have people follow it. So do you think there is an interface in this design and implementation, keeping the perspective of the human psychological perspective in mind as well?
Yeah, I think all of the factors that I mentioned go into whether or not you can have a develop a policy and implement a policy successfully around social distancing as one example. And I haven't talked about law as much, and I think your question invited me to think about policy more generally than law, but I'll say the interface of law here may be in, if you have a public health policy about social distancing, how is that enforced? What are the penalties for people who fail to socially distance, who fail to wear masks? And these are very difficult issues for society, because in the midst of a pandemic where so many people are suffering, and where they're suffering either illness, the fear of illness, or the loss of jobs, or trying to get access to food outside their homes, this question of how far should the state go, how far should government go in using the power of law to enforce these public health measures also becomes an area of controversy.
Right. Great. Thank you so much, Dean Bobinski. So again, we have, I think, 15 minutes left, and I wanted to have at least one more question each to both Raj and Prachi before we get to the audience. So Raj, very quickly, while we got a perspective on different critical parameters in design of these policies, we also understand that no public health policy could work in isolation. And with the COVID-19 pandemic in particular, we are seeing a lot of different issues, a number of different social issues around stigma, around domestic violence, mental health issues, suicides, abuse. What from your context, could be policy measures that could be intertwined with the public health policies to address some of these related issues in a pandemic condition that we are in, with the social distancing and working from home and other issues which are basic, limitations to human nature of interacting and socializing.
Thank you, Nikhil. I think, I'll just repeat what Dean Bobinski said very clearly, that, trust and top-down strategies to arrest pandemics like this often ignore the most common thing that is available in the community. And, even in this case, the policy is often ignored the primary care approach that countries like, United Kingdom and other countries have really used to the best ability. As Prachi said, we have a large of 25,000 of so PSCs and many sub-centers and around 5,000 odd community health centers that could have been actually galvanized into action to actually take this. And let us not forget that this, even in the slums of India and many other low-middle income countries, there are women groups and often robust social groups and knowledge that already exist. And the best thing would have been actually to not have a top-down strategy, but to involve these people at the level. And policies and programs to COVID-19 that do not recognize these realities will further jeopardize the survival of large segments of these, both urban and increasingly rural population, when the rural population opens up. What's important is an equitable approach to arresting this pandemic, is to understand these issues, acknowledge them, and change standard ways of treating the urban poor or the rural poor, create more participatory governance, improve the delivery of essential services. The social and economic fissures which has really been exposed by this pandemic will result in huge amount of social displacement and cause, in a place like India with chronic malnourished people, this is the making of a perfect storm. And this will result in mass unemployment, depleted social safety nets, and these are fertile breeding grounds for increase in chronic stress, anxiety, depression, alcohol, tobacco, substance abuse disorder, and self-harm. And we will be facing a pandemic of a different kind in the coming years. And, as I said, policymakers really need to take cognizance of this. At-risk population in India with pre-existing mental health issues, and this is highly underreported, is 150 million people. And to add to that, you now have survivors, your frontline medical health workers who have been abused, doctors who are being bashed up because they don't have faith in the system, and anytime an adverse adverse outcome happens, the hospitals being vandalized, all this is going to add to it. If you do not build trust into the system, if you do not deal with community-led participatory governance and include all segments of society in your policy, then this is bound to happen. And there is this great fear now among public health experts, and many conversations I'm having with friends and other people, both in my foundation and other ways, that also this excessive focus on managing coronavirus is likely to diminish care of people suffering from other health conditions. I mean, look at this. There are 1,200 deaths per day from tuberculosis alone in India. If you look at TB, malaria, and other infectious diseases like HIV, this entire lockdown has just thrown the lives out of gear, and they are not able to get diagnosed, they're not able to get medicines on time, they're not able to get counseling on time, and they're left to really manage on their own. Till date, even with the the unlockdown that's happening in India, basic services not still got back to back to normal. So policymakers will need to be attentive to clear communication about why they are using the adopted approaches, which services still remain available in the lockdown, what channels are there to ensure appropriate uptake, which social media, what channels on ground are you using, and they have to allay fears about care seeking and combating misinformation.
Right.
We talked about data, right? And data is important, but if you don't do this, and even data, even collecting of data, there has to be a consensus that it will be shared with the public or be in public domain. And this is not just to inform, but not just for this crisis. God knows, I think it's quite evident that there will be future pandemics that will only be able to dealt with if we have longer term health system capacity building, which currently has not happened or happened in some measures in the country.
Okay. No, thank you so much for that, Raj. I think in certain ways, what you spoke about, community participation. I think given the limitations on the systems and what you spoke about, the top down and the bottom up, I think these are some areas, as the policymakers look at addressing such future pandemics, these would be critical areas to focus on that can address a lot of the issues that you highlighted. But in fact, on the note that you sort of left, especially from this perspective of having people becoming a part of addressal, making data a part of it, to what Dean Babinski had also said, looking at the cell phone behaviors and looking at data from a psychological perspective that help in creating and designing and implementing policies. I would like to come to you, Prachi, on that. Also there was a mention of social media. So from your perspective, what are the innovative ideas and solutions from a digital perspective that India is currently looking at or could be looked at in addressing some of the issues that either Dean Babinski highlighted in terms of formulating, enabling formulation and implementation of policies, or addressal of pandemics and situations and challenges like what we have with the COVID-19, as Raj highlighted currently. What, according to you, could be the role of, what are the sort of innovative ideas in the digital space that are being considered, and what impact could they have? You are mute again, Prachi.
Thanks for the question, Nikhil. I think India very rapidly cleared the telemedicine guidelines, which were under evaluation for a long time. So that's a very big plus in this situation. I think a lot of people would be able to access OPD services without having to go to the hospital. In addition, if we just look at the digital framework, there are quite a few states which are adopting analytics based resource forecasting tools or resource estimating tools to understand based on the epidemic what kind of preparation they need to do. So but in India we have a basic challenge. I mean, unlike west where EHR, EMR, the basic digital infrastructure is present, our system is still manual. So for a lot of the digital uh, transformation to happen, that basic infrastructure has to there, because there is no input which is coming in directly in a real time basis. So this input again has to be manual at the moment. So I feel India must fast track its digital journey of digital transformation. It has a fantastic framework in form of national digital health blueprint. It can actually there are states which have their strategies in place. Delhi government is developing its own IHMS platform. So I think it won't happen readily, but if government is focused on it in 2 years' time with the current technology framework, India can actually leapfrog, because for West countries where the systems are already existing, for them to transform, it's a much more difficult journey. So India can actually leapfrog very fast. And in fact, like I said earlier, India can actually look at a online system of storing and sharing data, which is where patient is the main custodian of the data. So even before uh, uh, a lot of data privacy challenges get addressed, some of these interventions will be useful. But yes, Indian government will have to solve very critical challenges in this process, which relate to unique identification, which relate to data privacy. There is a data privacy bill currently resting in the parliament that needs to be ratified. So some of those challenges need to be addressed. But yes, I think India is prepared. If you look at various state policies and various national level programs, India is prepared for doing that. And
Okay.
we can see individual examples and use cases to see where it can go.
No, that's I'm so glad that that ends on a positive note. I know it's 6:57 now, so we just have a couple of minutes, uh, and I mean, thanks for that insight. I mean, it's good to know that some basic framework questions that we were discussing, whether it's on data, whether it's on enablement or formulation of policies based on information and data. I think we have certain systems in place uh, to, leapfrog, as you mentioned, from here in the right and correct direction to accelerate and make some of these ideas more sort of focused towards implementation rather than just speaking about them. But with that note, I would request maybe we can take a question or two from our audience. Heather, is there anything that you would like to post to the panelists in terms of questions from the audience?
Right now, you've actually answered every single question that's in the chat box. So thank you so much.
Okay, so that gives us maybe maybe 2 minutes more. I think I just had one quick question for Dean Babinski before we sort of end the session. So, Dean Babinski, I think one of the critical areas, in terms of addressing this COVID-19 pandemic is our search for a vaccine. But we have seen that while we have vaccines for a number of other critical diseases, there are legal and ethical implications. One key example that comes to mind is the HPV vaccine. But keeping in mind these legal and ethical implications, also a perspective of accessibility and affordability, all of these lying under the realms of a good policy, not just nationally but globally. What do you think would be the key areas in terms of a policy that would enable, as and when a COVID-19 vaccine is available to reach the people across the globe?
So we end on another easy question. You've specialized in these very large, important questions for the world in this pandemic. I would say, first, obviously, is the legal structure that's leading to the development of the vaccine all across the world. Everything from how we regulate research to how we develop the systems for determining intellectual property aspects of vaccine development and liability aspects of vaccine development for companies that would be bringing a vaccine to the world and the potential risks around liability. So that's obviously an important framework. But I think your question went far beyond that to say, well, how, assuming we have that vaccine, how do we get it to people around the world? And there you see different policy and legal issues having to do with accessibility, who pays the cost of those vaccines, how high will that cost be, whether or not systems can be put in place that minimize the cost to individuals, because if you create a barrier for the individual by requiring that they pay something for the vaccine, the take-up rates will be much lower than if you find a way to, through government support or other forms of support, make that vaccine as inexpensive as possible. For example, in the United States, where something called co-pays is an issue, it's where an individual may even be insured, but when they go and get a vaccine or some other treatment, they have to make a personal payment. So, and the effort in the US is to have the no copay, so that in private or governmental programs, the individual would not face a cost barrier to getting vaccines. And then on the legal issues, there's also the question of mandates for vaccines. And those have been an important legal issue around the world. And one of the first and earliest, most important legal cases involving public health in the United States that went to our Supreme Court actually involved mandatory vaccines for smallpox. And there, the US Supreme Court upheld the ability of the state to require a mandatory vaccine of its citizens. Yes, it intruded on the individual liberty to make a choice about whether or not to have a vaccine. But in that case, the government interest in protecting health was so compelling, and the measure of a mandatory vaccine was closely related to protecting against that disease. And the court said, yes, in that case, the state can mandate a vaccine even over an individual's personal decision. So sorry that that went somewhat longer. But
no, please. I think this was something that we really wanted to hear about, because this is going to be very critical in the addressal of this pandemic. So thank you so much for that. And thank you so much to the three of you for this interesting, insightful discussion. With that, I would hand it over to my colleague, Katie, for giving the closing remarks.
Thank you so much, Nikhil. As the Executive Director of International Advancement and Constituent Engagement here at Emory, I want to thank all of our panelists for your timely and important insights today on this critical topic. And thank you again to Nikhil and Neha for your time today and participating and taking time out of your busy schedule to bring yet another wonderful panel discussion in our series, Virus Without Borders, to our alumni community globally. Just a few reminders for all of our alumni in India who are participating here today. Please remember to join the Facebook group and the WeChat groups and stay connected with all of the wonderful programming that Neha and her cohort there on our alumni leadership community have put together for our alumni in India. Specifically in Delhi, and there's also a group in Mumbai for those who are participating from there as well. Also, please join our Emory Digital Engagement Hub, where you can find this recorded program, the rest of the series, and all the other digital recorded programs that we have through the Emory Alumni Association. And please go on to momentum.emory.edu to find ways where you can support our Emory healthcare workers, our students, our faculty, and our staff with hardship funds that are available during this critical time where so many people in our community are also suffering and working to help with the COVID crisis. Please mark your calendar and join us for the next in the series of Virus Without Borders on the physiological and psychological impact of COVID-19, working on the mind and spirit. That will take place on Thursday, June the 25th. And then there'll be our final one in the series on June the 2nd and July the 2nd, excuse me. You can find more on that on our landing page, the Virus Without Borders landing page on the Emory website. This is the end of our presentation for today. Thank you again to all of the panelists, and thank you for participating, and hope to see you on our next presentation on the 25th. And take care and stay well.
Thank you.
Thank you, Katie, for having me. Thank you, Nikhil.
Thank you, everyone.
Thank you, everyone.